Good evening, pen and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 19th episode of Optometry Series 2.0. I'm very happy to welcome my team members, Ms. Meenakshi and Ms. Anshi ma'am. Thank you both of you for joining. Anshi ma'am, so last episode we dealt with anatomy of retina. So today we're going to definitely deal with retinal diseases. So how are we going to deal with this topic, ma'am? Because it's such a vast topic. And please tell us about our moderator also, ma'am.
Thanks, Gomati, for the introduction. Yes, as we've already completed retinal anatomy last session. This session, we have divided retina into two parts. We'll be having retina disease 1 and retinal disease part 2. So this particular session, we'll be having on retinal vascular diseases and the structural changes which happen in retina because of those diseases. And today's moderator with us is Mr. Kishor Choudhury. He's an assistant professor from the School of Optometry, Sri Shankar Dev Netralaya. I'm very happy that sir could join us, and today we'll be awaiting from him to get insights on this particular topic. So without much further delay, I request the MC to please introduce our moderator for today.
Thank you, ma'am.
Hello everyone, and welcome to the viewers. First, let me introduce myself. I'm Endalan from C18 batch, and I'm also a member of DIO research team. It gives me immense pleasure to welcome you all today for today's episode of Optometry Series 2.0. We have an excellent session planned for today, and we have pleased to have you with us today as a moderator, Mr. Kishor Choudhury. Mr. Kishor sir completed his undergraduate training in optometry from LH School of Optometry at BITS Pilani in 2002. He later obtained his Masters of Optometry at Amity Medical School at Amity University and went on to complete an MBA from Sikkim Manipal University. Currently, he is pursuing his PhD at National Institute of Medical Sciences at Jaipur. He has begun his professional career as an optometrist at Sri Sankaradeva Netralaya in 2002, and between 2009 and 2011, he worked in Abu Dhabi at UAE, gaining valuable international clinical exposure. At present, he serves as an assistant professor at School of Optometry at Sri Sankaradeva Netralaya. Kishore sir has several academic publications to his credit and has co-authored an optometry textbook. In addition to his academic role, he is also an independent clinical practitioner at his own clinic, where he practices advanced contact lens practice, including square lens, rosque lens fitting. He also practices as an ocularist with expertise in ocular prosthetics. We are truly honored and delighted to have him with us today as our moderator. Welcome, sir.
Thank you.
Please join me in giving a warm welcome to Mr. Kishore Choudhury, sir. And now, moving on to our speaker for today's session. Our speaker is Miss Manisha. She is a third year undergraduate student of DIO and also a member of DIO research team. I'm passing over to you, Manisha. Thank you.
Good afternoon, everyone. Today, we are going to see about diseases of retina. Let's have a quick recap on anatomy of retina. Retina, the innermost tunic of eyeball. It is a thin, delicate, and transparent membrane. It is the most highly developed tissue of the eye. It appears purplish red in color due to the visual purple of the rods and underlying vascular choroids. The retina extends from optic disc to ora serrata. The total surface area is approximately 266 mm square. The thickness and structures vary in different regions. The retina is grossly divided into three distinct areas: optic disc, macula lutea, and peripheral retina. Now let's move on to the retinal disorders. The first one is congenital and developmental disorder. It is classified into four types. Anomalies of optic disc are crescent, congenital pigmentation, coloboma, drusen, and hyperplasia. We'll be seeing in detail of anomalies of optic disc in next slide. The second one is anomalies of nerve fiber, as medullated opaque nerve fibers. The third one is anomalies of vascular element, which are persistent hyaloid artery, and congenital tortuosity of retinal vessels. The tortuosity means abnormal twisted blood vessels. The fourth one is anomalies of retinal proper. They are albinism, congenital night blindness, congenital day blindness, Orchis disease, congenital retinal detachment, and coloboma of fundus. The anomalies of optic disc are, the first one is coloboma of optic disc. It results from the failure in closure of the embryonic fissure. It occurs in two forms. The coloboma is nothing but small missing part of the eye tissue. The second one is drusen of optic disc. They are interpapillary refractile bodies which usually lie deep beneath the surface of the disc tissue in childhood and emerges out by the early teens. It will look like a small yellowish part in the optic disc. The third one, we have hypoplasia of optic disc. It may occur as an isolated anomaly or in association with other anomalies of central nervous system. The hypoplasia is an underdevelopment of the optic disc. These are the images. This is the persistent hyaloid artery in the optic disc fundus. Next, we move on to vascular disorders of retina. There are 7 common vascular disorders. The first one is retinal artery occlusion, retinal vein occlusion, diabetic retinopathy, hypertensive retinopathy, sickle cell retinopathy, retinopathy of prematurity, and retinal telangiectasia. First, we move on to occlusion disorders. There are 4 types in occlusion disorders. The first one is central retinal artery occlusion. It is a sudden blockage in central retinal artery, and it is pathophysiology is harmless. The retinal ischemia. The clinical feature are sudden painless vision loss. The clinical sign of CRAO is cherry red spot, and the management for CRAO is ocular massage and reduced IOP. The second one is BRAO. It occurs due to blockage of branch artery. Pathophysiology is local ischemia. The clinical feature is sector field defect. In fundus, a sector whitening is seen, and the management is same as CRAO. CRVO, it occurred due to blockage of central retinal vein. Pathophysiology is venous statosis. There will be a congestion in venous statosis, and clinical feature is blurred vision. In fundus, blood and thunder appearance will be seen, which is known as tomato splash. The management for CRVO is anti-VEGF, which is vasoendothelial growth factor and pan-retinal photocoagulation. And the last one is BRVO, which is branch vein occlusion. Pathophysiologist arteriovenous crossing damage happens, and the clinical feature is sectorial field loss. And hemorrhages seen in fundus. The management for BRVO is laser and anti-VEGF injections. We have retinal artery occlusion. The etiology of retinal artery occlusion is hypertension, cardiovascular disease, emboli, and atherosclerosis at lamina cribrosa, retinal arteritis, angiosperm, raised intraocular pressure, and thrombophilic disorders. The types of emboli are cholesterol emboli, which is cholesterol accumulation, and calcium emboli, and platelet fibrin emboli. The clinical types of retinal artery occlusion are CRAO, BRAO, cilioretinal artery occlusion. Retinal vein occlusion, the etiology is anterior venous crossing compression, hypertension, diabetes, hyperviscosity states. The classification of a retinal vein occlusion is central artery vein occlusion, non-ischemic, ischemic branch retinal vein occlusion. The non-ischemic central retinal vein occlusion, the patient will be experiencing mild to moderate vision loss, no RAPD, dilated tortuous vein, few hemorrhages, and mild macular edema are seen in the fundus. Ischemic CRVO is sudden severe vision loss, RAPD is present, tomato splash is seen in fundus, and numerous hemorrhages, cotton wool spots, and neovascularization is common. The management for retinal vein occlusion is to first control the systemic disease, anti-VEGF injections, and laser pan-retinal photocoagulation for neovascularization. And for severe cases, vitrectomy is advised. Next, we have retinopathies. The first one is diabetic retinopathy. It is a microvascular retinal damage due to diabetes mellitus. The pathophysiology is hyperglycemia, capillary leakage plus ischemia. It leads to neovascularization. The clinical feature is blurred vision and floaters are seen. The fundus changes include microaneurysm, hemorrhages, exudates, cotton wool spots, and neovascularization. The management for diabetic retinopathy is anti-VEGF, pan-retinal photocoagulation, and diabetic medication, diabetic macular edema treatment. And next we have hypertensive retinopathy. It occurs due to retinal vascular damage due to the hypertension. The pathophysiology, arterial narrowing is seen, leakaging in blood vessels. Clinical features, vision usually normal, and the fundus changes includes arteriovenous leaking, cotton wool spots, flame-shaped hemorrhages, and exudates are seen. Management for hypertensive retinopathy is to control BP. Radiation retinopathy, it occurs due to a retinal ischemia and post-radiation. Pathophysiology, endothelial damage causing capillary closure. Clinical features, decreased vision will be there. Fundus changes, cotton wool spots, hemorrhages, and neovascularization. Management for radiation retinopathies, anti-VEGF injections. Next, we have sickle cell retinopathy. It occurs due to vaso-occlusion by sickled RCB. Pathophysiology, ischemia, causing neovascularization. And clinical features are floaters and decreased vision. The fundus changes are CFAN neovascularization and salmon patches. And management is laser and anti-VEGF injection. And next is CMV retinitis. It is defined by opportunistic infection in immunocompressed comprised. Pathophysiology, viral necrosis of retina. Clinical features are floaters and decreased vision. The fundus changes include pizza pie necrosis. And management is Gansero clover. Next is hypertensive retinopathy. This is a detailed explanation of hypertensive retinopathy. The hypertensive retinopathy, it is referred to fundus changes occurring due to systemic hypertension, although the term suggests retinal involvement alone. Clinically, the hypertensive hypertension includes changes in hypertensive retinopathy, hypertensive choroidopathy, hypertensive optic neuropathy. The pathogenesis is vasoconstriction, arteriosclerosis, and increased vascular permeability. The hypertensive retinopathy is classified into two types: chronic hypertensive retinopathy and malignant hypertensive retinopathy. The fundus changes in chronic hypertensive retinopathy are arterio-narrowing, arteriovenous leaking, copper wiring, silver wiring, flame-shaped hemorrhage, hard exudates, and cotton wool spots. The stages of hypertensive retinopathy, according to Kate Wagner classification, In grade 1, we'll be seeing mild arterial narrowing. In grade 2, we'll be seeing marked narrowing plus shallow sign. In grade 3, all changes in the grade 2 plus copper wiring, hemorrhages, cotton wool spots, and hard exudates are seen. In grade 4, with the changes of grade 3 and silver wiring and papilloedema are seen. Next is malignant hypertensive retinopathy. It has severe blood pressure rise, retinal hemorrhages, cotton wool spots, choroidal ischemia, and optic disc edema are seen. Management for hypertensive retinopathy. In mild cases, the patient has to control the blood pressure. In moderate cases, BP control plus evaluation and reduction of vascular risk factors. In malignant cases, urgent antihypertensive therapy is advised and gradual BP reduction to prevent optic nerve and CNS hypoperfusion. Next, diabetic retinopathy. The diabetic retinopathy is the leading cause of blindness, and it is caused by retinal microangiopathy, and the risk increases with duration of diabetes. The risk factors of diabetic retinopathy are duration of diabetes, poor metabolic control, hypertension, pregnancy, hyperlipidemia, and smoking. The classification of DR, it has 4 classification. The first one is NPDR, non-proliferative diabetic retinopathy. The second one is proliferative diabetic retinopathy. The third one is diabetic maculopathy, and the last one is advanced diabetic eye diseases. In mild NPDR, the earliest stage of diabetic retinopathy with minimal microvascularization damage, and in fundus microaneurysms are seen, and no other retinal changes are seen. In moderate cases, more than mild but not reaching the severe criteria. Microaneurysm, dot and blot hemorrhages, hard exudates, cotton wool spots, venous bleeding may be present in the fundus. In severe NPDR cases, high risk of projection to PDR, no neovascularization are seen. 4-to-1 rule, which is 4 quadrants of intraretinal hemorrhages or microaneurysms, or in 2 quadrants of venous bleeding, or 1 quadrant of intraretinal microvascular abnormalities. Next one is PDR. The presence of neovascularization is seen, and neovascularization of disc or elsewhere is seen in the fundus. Pre-retinal or vitreous hemorrhage and fibrovascular proliferation is seen. It has a high risk of tractional retinal detachment. The next one is diabetic maculopathy. It involves macula. It causes leading to causing of visual loss. The types is focal, diffuse, ischemia, and mixed. In focal, we'll be having localized leakage from microaneurysms causing succinate exudates. In diffuse, there will be a generalized retinal thickening. In ischemia, enlarged effusion zone, poor prognosis, and in mixed maculopathy. Advanced eye disease, it is the end-stage complication of long-lasting proliferative disease. In fundus, extensive fibrovascular proliferation, tractional or combined retinal detachment, recurrent or non-clearing vitreous hemorrhage, neovascularization, glaucoma is seen. This is the OCT image, and there will be a hard exudate seen in the retinal layer. The management of diabetic retinopathy, the patient has to control the metabolism, and next for controlling the neovascularization, anti-VEGF injection is given, intravitreal steroids, laser photocoagulation, and pars plana vitrectomy is done in severe cases. Next is solar retinopathy. It is also called as photic retinopathy. It occurs due to the retinal damage caused by the direct or prolonged exposure to the sun or intense light. Example, eclipse viewing or welding arc. The pathophysiology is high energy visible light, thus ultraviolet light causes photochemical injury to the RPE and photoreceptor layer, especially at the fovea. There may be no thermal burn. Injury is primarily known as toxic photochemical damage. The clinical features are sudden central blurring, central or paracentral scotoma, metamorphosia. Symptom appears hard after exposure. Fundus finding, small yellow spot or foveal granularity, later small central foveal depression or RPE mottling. In OCT, foveal outer retinal disruption is seen. Management, mostly conservative. Vision often improves in weeks or months. Sunglasses plus avoidance of further exposure to sunlight or intensive light. No specific proven treatment, but steroids sometimes tried, but not routinely recommended. Next is sickle cell retinopathy. It is defined as retinal ischemia and vascular abnormalities due to sickling of RBC cells in patient with sickle cell disease or sickle cell trait. The pathophysiology is sickle cells RBC obstructs small retinal vessel causing ischemia and vasoendothelial growth factor release and peripheral neovascularization is occurred. And CFA neovascularization forms at the ischemic borders. The clinical features are often asymptomatically in earlier stages, flutters or sudden visual loss if vitreous hemorrhage occurs. Progressive peripheral vision changes in the advanced state. The fundus finding, according to Goldberg classification, stage 1 peripheral arteriolar occlusion, in stage 2 peripheral anteriovenous anastomosis, in stage 3 CFA neovascularization, in stage 4 vitreous hemorrhage, in stage 5 tractional retinal detachment. The management is laser photocoagulation for neovascularization, anti-VEGF for hemorrhage or neovascularization, surgery for tractional retinal detachment, systemic sickle disease management. Next is retinopathy of prematurity. It occurs in prematured infants, low birth weight, oxygen exposure, low oxygen exposure. High oxygen exposure. The stages of retinopathy of prematurity. The stage 1 is demarcation line. In stage 2, ridge formation. In stage 3, fibrovascular proliferation. In stage 4, subtotal retinal detachment. And in stage 5, total retinal detachment is seen. These are the zones and stages of ROP. The pathogenesis, normal retinal vascularization occurs under the influence of VEGF, reaching nasal periphery by 8-month gestation, temporary periphery 1 month of after birth. In premature infants, high oxygen level causing down regulation of vasoendothelial growth factor. It arrests of normal vessel growth. Later, due to increased metabolic demand, excessive production of VEGF and IGF-1, it leads to abnormal neovascularization followed by fibrovascular proliferation. Progression traction results in retinal detachment. The management, screening of preterm babies, laser photocoagulation, and anti-VEGF in selected cases. Treatment, laser therapy or cryotherapy, and ETROP recommendation, laser preferred over cryotherapy. Laser treatment, laser photocoagulation is done using diode laser, frequency doubled ND YAG laser, and surgical treatment, lens sparing vitrectomy, endolaser photocoagulation, and retinal reattachment measures. The categories. First one is specific retinal vasculitis. Definition: vasculitis with identifiable systemic and infectious or autoimmune causes. The etiology is for infectious tuberculosis, syphilis, HSV, toxoplasmosis, HIV, and for autoimmune sarcoidosis, SLE, HLA-B2, B27, uveitis. For malignancy, leukemia and lymphoma. The features are blurred vision, photophobia, ocular pain. The ocular pain is seen in inflammatory forms. The fundus changes includes periphlebitis, arthritis, cotton wool spots, hemorrhages, vascular occlusion, sheathing, frosted bands pattern. For management, steroids plus immunosuppressants and neovascularization and macular edema has to be managed. Next is non-specific retinal vasculitis. It is vasculitis without identifiable systemic cause. It is a part of idiopathic ocular inflammation. The cause is idiopathic retinal vasculitis, IRVAN syndrome, intermediate uveitis, pars planitis, post-infectious immune vasculitis. The clinical features are floaters, reduced vision, recurrent inflammation. Sometimes it can be asymptomatic. The fundus changes includes venous sheathing, exudates, peripheral leakaging, macular edema. The management, corticosteroids for topical and systemic, periocular steroids, immunosuppressants if recurrent, laser for ischemic areas. The next is Eales disease. It is idiopathic peripheral venous vasculitis, which is more commonly seen in young adults, and it is common in Indian subcontinent. The causes of Eales disease is hypersensitive to Mycobacterium tuberculosis antigen, causing inflammation in venous occlusion. It causing ischemia, leads to neovascularization. Clinical features: floaters, sudden visual loss due to vitreous hemorrhage. And the fundus changes includes periphlebitis, venous occlusion, CFAN neovascularization. The management for Eales disease is oral steroids for active vasculitis, ATT if tuberculosis test is positive, laser photocoagulation to ischemic retina, and anti-VEGF for neovascularization, vitrectomy for non-clearing vitreous. Next is macular hole and telangiectasia. The macular hole is full thickness foveal defect. It occurs due to vitromacular traction. The patient will have central vision loss, and round foveal defect is seen in the fundus. The treatment for macular hole is PPV surgery. Next is lamellar hole. It is a partial thickness hole occurred due to the traction. The patient will have mild vision loss. The fundus changes include irregular fovea. The treatment is observe or surgery. The macular telangiectasia type 2, it occurs due to neodegeneration plus vascular changes. It is known as perifoveal capillary dilation. The clinical feature is metamorphosia. The fundus changes, temporal parafoveal graying, and treatment anti-VEGF for neovascularization and monitoring. This is the image of a macular hole. The etiology is idiopathic in most common and trauma, high myopia, macular edema, post-cystoid macular edema, vitreomacular traction. The macular hole will leads to central vision loss and metamorphosia. Classification in stage 0, impending hole and no foveal break is seen. The OCT features are VMT without foveal changes. Clinical features are often asymptomatic. In stage 1, yellow spot is seen, foveal detachment forming a small cyst. In OCT, systemic elevation of fovea is seen. Clinical feature is mild metamorphosia. In stage 1B, yellow ring formation, ring-shaped foveal detachment. In OCT, wider cyst and operculum formation. Clinical features, distortion and blurred vision. In stage 2, small full thickness macular hole, which is lesser than 400 μm. OCT, FTMH with partial VMT, central scotoma is seen. Stage 3, full thickness hole, which is lesser and equal to 400 μm. It is attached with posterior hyaloid. The OCT features are larger FTMH without posterior vitreous detachment, and clinical feature is bigger scotoma. In stage 4, full thickness macular hole with complete PVD. OCT features are hole along with operculum floating. The clinical features are bigger scotoma. This is a new classification, OCT based. It is by International Vitreomacular Traction Study Group. There are categorized by size, cause, and vitreous status. By size, small, lesser than 250 μm, medium 250 to 400 μm, and it is known as large, above than 400 μm. By cause, primary it is idiopathic, and trauma, myopia, and post surgery is known as secondary. And by vitreous, with VMT and without VMT. The findings are round oval foveal defect, yellow deposits at the base of hole, operculum may be seen floating above the hole, sharply demarcated edges, retinal pigment migration in chronic cases. The symptoms are central vision loss, metamorphosia, difficulty reading, central scotoma, and distortion of straight lines. The management is given as stage wise. For stage 1, usually absorption and 50% may resolve spontaneously. And for stage 2 to 4, pars plana vitrectomy and internal limiting membrane peeling and gas tamponade. And for vitreomacular traction related small hole, orchid plasmacin injection rarely used now. Adjuncts, face down positioning post-operative. It depends on the surgeon. Prognosis, better in small, recent hole, poorer in larger or long-standing hole. The next one is retinal telangiectasia. Primary retinal telangiectasia is caused by idiopathic congenital or acquired retinal vascular malformation. The features are irregular capillary dilation and segmental dilation of venous, venosul, and arterioles. The types are idiopathic juxtafoveal retinal telangiectasia, Coates disease, and Leber's millinery aneurysms. The first, idiopathic juxtafoveal retinal telangiectasia. It is also known as idiopathic macular telangiectasia. It is a rare condition and it is classified into group 1, group 2, group 3. And next is Coats disease. It is a severe form of retinal telangiectasia and it is a idiopathic congenital vascular malformation. The clinical features are usually unilateral, dilateral, tortuous retinal vessels, and multi-aneurysms near the optic disc and posterior pole are seen. The investigation for Coats disease is fundus fluorescein angiography. The treatment is cryotherapy and laser photocoagulation. The last is Leber myelinaria aneurysms. It is a localized mild form of Coats disease. It is mostly occurred in adults. The features are fasciform and saccular aneurysms and localized exudation. The treatment is direct photocoagulation of abnormal vessels. These are my references. Thank you.
Thank you so much, Manisha. Yeah, it was a very detailed and elaborative presentation on retinal diseases. Now I request the moderator, sir, to add your valuable clinical input, sir.
Yeah, thank you. Thank you, Manisha. It was a very nice presentation and it is very elaborative. You have covered all, mentioned everything almost. Okay, my point is here
Thank
from
you,
the
sir.
optometry point of view, what we have to do and what will be the summary of retinal vein occlusion actually, and what is the common thing we can see here. If you see in vascular the occlusion diseases, there are main causes systemic diseases. So as an optometrist, when we take the history, the systemic condition, about the systemic condition, we must note it down. If you see, the age is also one very important factor. Mostly 90% cases we see at the more than the 50 years of ages. In the young ages, due to heart diseases, or if the BMI is high at the age of 20, then also can have the BRVO. Okay, so these are the causes we should know: diabetes, hypertension, heart disease. Then if the lipid profile is high, then also we have to check it. So regularly we have to do the eye examination. And the other part is, the remaining part is that whatever you have told about the management, that is all the already established management or treatment line. That is the anti-VEGF or corticosteroids or PRP. Okay. So whatever the new therapy has come in, or it is just in research, that is the gene therapy. Okay, so that will help the management line. Although it is not a reversible one to to reverse the blockage, but gene therapy will help. Okay, and then we have something called sustained release drug delivery and neuroprotection. Okay, these are the new line of treatment which will help the patients to at least the restore the vision. And diabetic is a very it is the leading causes of blindness. After, if you see the cataract and the glaucoma and the refractive error, then now it is the diabetic retinopathy. So we have to concentrate, we have to make the aware of the patient. And the examination part, regularly comprehensive eye examination is must. What happened when we do the independent practice, there only we have check the, or we are regularly doing the slit lamp examination with the anterior segment. We just left out the posterior segment. So if it is possible, then dilated fundus evaluation is a mandatory checkup, especially the patients who are old age. Okay, and patients who are having the heart disease, even in the young patients, or who are having the obesity. So for those patients, we should have a mandatory fundus examination, because these, when we take the history, these retinal vascular occlusion diseases are, if you see, is a sudden vision loss will be there. So early detection and their meticulous management is a very important factor. So these are the point we have to note. Commonly, we have to check the vision and then intraocular pressure. And if it possible, if you see any glaucoma sign or symptoms, then definitely we have to do the gonioscopy also, fundus evaluation, and any main major examination will be OCT, fundus examination, and the fundus fluorescein angiography, fundus photo, all these things we can do it. So that is from my point. So I suggest every optometrist to go for a fundus evaluation if any suspicious causes will be there. So this is the from my part. Thank you.
Thank you, sir. Thank you so much. From the student's perspective, we do have certain questions for you, sir. I'll read it out for you. The first one is why taking a general or systemic history is very important along with retinal findings.
So this is the common causes. Here we have learned, if we just summarize this, all the retinal vascular diseases occurs mostly the secondary causes or the
Sir, I'm sorry to
primary
interrupt.
causes is the systemic diseases. And people, even I healthy. Yes, ma'am.
Yeah, in between your network was struggling, sir. We couldn't hear you properly.
Sorry. Okay. So that's why the systemic diseases history is very important. Even the family history is also important. If suppose some persons in the family, they are having the glaucoma or the diabetes, the person who is not having till now the diabetes or glaucoma or the hypertension, they should also go for a total health checkup. So that's how it will help. Otherwise, see, this is, I told before itself that it is not a reversible one. Once it is only the preventable, whatever the vision loss will be there, the recovery is very less. Almost you can see that if the visual acuity is 20/70, then it will be improved up to 20/40 or 20/50. It is not beyond that. After having the PRP or the even anti-VEGF or even the corticosteroids. See, so that's why the primary management will be taking the control in the systemic diseases.
Thank you so much, sir. The next
Thank you.
question is, from the Optum perspective, what is the battery of tests that they should follow in assessing the retina?
So that is the point also I have already mentioned. I believe everybody should keep something to where they can check at least the IDO, or nowadays there are so many instruments are there to check the where we can check the fundus evaluation. And by law also we can do the dilatation. So there will be no problem. Only we have to learn, at least we can see the hemorrhages, at least we can see the macular edema, because from the other thing like OCT and keeping the FFA, this is a tertiary care. So at least in the primary care, what we can do, we can keep one fundus evaluation instruments. So that will help. And one thing also I suggest that please do the RAPD checkup is a very mandatory one, important one.
Yes, sir. Thank you so much. Sir, am I audible for you?
Yeah, thank you.
The
Yes,
next
yes, ma'am,
question,
yes.
yeah. The next question is, what are the common left out findings from your clinical perspective, sir? Easily missed out findings or easily mistaken findings or something.
So I think it's the macular edema. So it is just commonly missing because see the main part of the vision loss and unilateral cases we missed out actually. Sometimes if it is happen in the young age, around young means like at least like 55 or 57, then we do not, and patients are not having any systemic condition, then we miss that part and we believe that okay, this might have the amblyopia or the laziness from the before itself like that. So proper history taking and in this about this retinal vascular occlusion diseases, I believe that macular edema also can be we can miss it, and for that we have to do regularly a Amsler test. If somebody suggests that there is something metamorphopsia or the central vision difficulty or blurring of vision, initially they will have blurring of vision. Later on, it goes to the vision loss. So I suggest specially to have the Amsler chart or Amsler grid to perform in the clinic.
Thank you so much, sir. And the last
Thank
question
you.
is there any tips for the students to remember or understand the vast classification of retinal diseases?
So far, like whatever she has already given all the name of the diseases, so I don't find anything shortcut method
Sir,
to remember all the from the diabetes. What we can have diabetic retinopathy, from the hypertension we can have hypertensive retinopathy. Like that only we have to remember. And only one point I just want to ask, like everybody knows about the VEGF actually. What is that anti-VEGF? That is the basic treatment of the all these macular edema or the diseases, retinal vascular diseases. How it actually work? What is that actually? So in actually what happened in macular edema, there are elevation of protein called the vascular endothelial growth factor. And this VEGF, what happened? They actually cause the blood vessel fragile and the leakage occurs. And these VEGF, they also create the new blood vessels in our body through a process called the angiogenesis. So through the angiogenesis, they grow, or there will be a neovascularization. So once this neovascularization occurs, that is the severe cases then again.
yeah, sir. Thank you so much, sir.
Thank you so much. Yeah, thank
Anshi
you.
ma'am, do we have any questions for our moderator, ma'am? Komati, am I audible? Yeah.
Yes, Meenakshi.
Sorry, Meenakshi, I wasn't able to hear what you said.
Sorry, ma'am. We, from students' perspective, all the questions are done. Do we have any questions from your side to our moderator today, ma'am?
No, I think it was a very elaborate session. Thank you so much, sir, for your input. It was very
Thank
nice
you, ma'am. Thank you,
to
ma'am.
get
Thank you for the
inputs from the
opportunity
clinical
given.
side.
Yeah,
Yes,
thank
and I
you.
would also like to congratulate Manisha. She did a very well explanation of all the tabular form that she has done and concise. She tried to make retinal disease, which is very difficult. So, as you said, when we are trying to see a patient, we should remember systemic diseases, and that is something which would be a very good take-home message for today. So, thank you so much, Kishor sir, and thank you so much, Manisha.
Thank you, ma'am.
Efforts well
Thank you.
put. Yeah. Over to you, Gomati.
Yes. Thank you, Anshi ma'am. Thank you, Meenakshi and Kishore sir, for the Q&A
Thank you,
session.
ma'am.
Thank you so much for joining with us, sir.
Yeah, thank you.
Wonderful presentation, Manisha. Best wishes for your future.
Thank you,
Dear
ma'am.
audience, thank you all for your continued support towards Optometry series. If you like this video, give a thumbs up and share with all your friends. Admissions are open for Pan-India internship and fellowship courses at Dr. Agarwal's Institute of Optometry. For more information about this, please check the description box. Meet you all in the next episode. Until then, take care. Thank
Thank you.
you, team. Bye,
Thank you.
everyone.
Thank you, sir.